are joining. We can give them a few more seconds, but then we can get started. Shazad, I see you are on, so I anticipate you're doing the first slides again for us today.
Absolutely. I am ready to go.
Wonderful. Okay. Why don't you just go ahead when you're ready, and I will advance them for you.
Thank you. Okay, so thank you everyone for joining our monthly PI coordinator call. We had a similar call on Tuesday morning and shared the same content essentially with everyone over there. So the overview of today's call is, Michelle, next slide, is to just review some of the data on the activation recruitment processes. I'm going to share a couple of new things that we are going to be rolling out. So we'll sort of share that with the group. Then Michelle will talk about the consenting processes, how to use some reports, exceptions, and other tools to stay on top of study activities, and then some nuggets about study monitoring. So next slide, please. As of earlier this week, we had 41 sites that have been selected to participate. Of these, 35 are active and enrolling. 2 will be submitted to the CCHNC IRB after their continuing review is completed, and 4 are completing and finishing up their IRB documents and reviewing the contracted requirements and trainings. 128 patients so far have been randomized, woohoo! But we still have some gaps that you will see in the next slide. Almost 3/4 to 80% of the sites that have been activated have recruited at least 1 patient, with CHKD in Norfolk and Cincinnati leading the pack with 12 and 11 enrolled randomized patients so far as usual. So big shout out for them. Nationwide also recruited 2 patients last couple of weeks. So another shout out to the Nationwide team. Good job. Another sort of kudos that needs to go out to everyone of all the sites that have been participating is that the QI team has been monitoring the pre-consent log submissions, and none of the sites met our threshold of not submitting for 2 consecutive weeks. So another kudos and shout out to everyone who has been paying due diligence and attention to making sure that the data is submitted in a timely fashion. Next slide, please, Michelle. This is just a graphical depiction of the different sites and how many patients are being enrolled and randomized at each site. As I just shared, CHKD and Cincinnati is leading the pack, but there are a good number of sites that are in the top quartile of the randomized graph as well. So keep looking and keep paying attention to new entity starts at your specific areas. The next slide will sort of show us where we are at and the current state with how many patients have been randomized, with the green line sort of depicting our goal at this timeline into the trial and the study. The gap is about 154 patients, which is somewhat sobering, but we are making some progress. And I'm going to sort of share the next slide that what we are going to be thinking of doing to hopefully close that gap over the period of the next few months. So this is a spread matrix that was sent out to some sites earlier that is trying to gauge at how the process of identification, approaching, and consenting eligible candidates exist in each site. And the goal is actually to get a sense of how hardwired the process is. So as part of our deep dive that we have been doing as a group, we are actually going to select out some sites that have some that have significant patient population that should be eligible for recruitment and identification, and trying to take a deep dive based on this spread matrix, or we are calling it engagement QI self-assessment, and then help each site identify opportunities for improving and hardwiring the process. I will be sending an email out with a SurveyMonkey link that has this spread matrix on it to some of these selected sites, so stay tuned for that. This will have more information, and would love to have the feedback from each site, selected site, back to us within a week to 10 days at the max, so that we can then start working with the sites to help them ramp up. Next slide basically goes over the key, how to rate that spread matrix, with blank having no idea about what your current status is, to 5 being on top of every single thing that goes on. I will stop here for a second and see if anybody has any questions before handing over to Michelle to go over the consenting process. I guess not. Quiescence is reflective of remission in my clinical practice, so I would think that people are on board then. Mike, I don't know whether Mike is on the call or not, but
I am on the call, and I agree. And you know, I think this is sort of the midpoint in our study, and it's time to sort of re-energize and you know, we can do this.
We can do this. Absolutely. Okay, Michelle, all yours.
Okay, thank you. And thanks everyone for joining. I know there was a little overlap with another ICN call, so we will work to not have that happen in the future. So I appreciate you all who were able to join today. It looks like we have a pretty good crowd. Okay, so consenting, we just wanted to talk a little bit about this today, and then we're going to talk more about it in the future, either next month or in April, and our regulatory specialist will go over some other details. But we've had some problems and some continuing problems with consenting, so we wanted to just go over a couple of highlights today, and then we'll go through more in the future. So, and just as a reminder, no activities related to research should be completed until after the informed consent process has taken place, and the process begins when a potential research participant is initially contacted, and ensure you have the most recently approved IRBA documents. I know Stephanie had to do another kind of continuing review, or whatever we're calling it here, update, and so she'll be reaching out with any updated documents to you all very shortly. But the ones you have now are good, that she sent to you in December, and those should be the ones you are using. If somebody is listening to me say that and didn't get them or has a question, please feel free to reach out to me so that I can talk to you about that and make sure to link you in with Stephanie and make sure you have the right documents. Okay, so this is just a little bit of a look at our consent form. I don't have the whole thing on here. I have the first page. This is the master consent, and so for your site, it will have your site's principal investigator's name and telephone number on there. For the master, we have that you know, blank. And then taking a look at page 8. So in our consent form, page 8 of the consent form is the first time that the participant has to do anything. And so on there, we ask about the biologic samples, the blood samples, and they have to either check or X or initial at the bottom of the page there where it says, I've been told about this option and know what I am expected to do. And so they either agree to the collection of their blood for research purposes or do not. So they have to do something there so that we know what their decision is related to that. Okay, and then the last page of the consent form with the signatures, we want to just make sure that it is signed. Without a signed consent, we cannot participate in the study. And so as you go through the document for your printed name of your research participant, that is going to be the kid's name. So any child under 18 that name would go there. And remember that any child under 18, because for the study we can enroll people over the age 18 and over. And so printed name of child, and then for the signature of research participant indicating consent. If the child is under 18, that line will be blank. The next line, signature of legally authorized representative, that is where the parent or another legally authorized representative would sign and date the form, indicating they are consenting for that child to be in this research study. And then lastly, the coordinator or whoever is doing the informed consent with the family, most often it's the coordinator, will sign on the line of the signature for the individual obtaining consent. So that is all for children under the age of 18. For participants who are 18 to 21, because we can enroll those participants in our study, they would print their own name, printed name of research participant, they'd put their own name there. And then on the second line is where they would sign, because they are 18 or over, and so they can consent for themselves. They would sign and put the date. And then the next line, the signature of the legally authorized representative, would be blank. And the final line, again, would be the coordinator or the person at your practice, at your site, doing the informed consent. So that is what it should look like. We should not have, for example, the kiddo signing the signature of legally authorized representative next to the parent or anything like that. So just make sure you keep those signatures, one per line, and on the appropriate lines as you go through them. And then many of you also have an assent form, I just wanted to highlight the items there that the children should be assenting to and signing if they are doing that. Now, per Cincinnati Children's standards, any child 11 or older should be signing an assent form. I know some of you at your sites will have different standards. I know some sites say as low as 8 or 9. So if that is your site standard, go ahead and have your 8 or 9-year-olds do it as well. You can be consistent with your site, and that's okay. But you have to do 11 or older, since you all are relying on the CCHMC IRB. Okay. So then on the second page of, on the fourth page of your assent form, is the blood samples option again. And so after the child reads through that, they can either X or check or initial that they agree to allow the collection of their blood or do not agree. And then the child will have to sign however they can. Print, if they write in cursive, they can do that too. Sign and date the form at the bottom, and then you all, the coordinator or PI or whoever is assenting the child, would sign under signature person obtaining assent and date it as well. So those are the highlights of that. I'm going to go on to the next slide too, and then come back to that, but you need to upload these forms into the consent management system that we are using for the study. And as part of uploading your consent assent forms, you also need to upload your knowledge confirmation survey. So hopefully you all are doing this and this is clear. If it's not, you can reach out to Cassandra Dodds, or you can reach out to me and I will loop you in with her. But again, you need to be uploading your knowledge confirmation survey with your consent documents. You just scan them together. So every consent that is uploaded to the consent management system should include the knowledge confirmation survey. The survey should be the last page of the uploaded document. And if you have questions, please email Cassandra Dodds. I will send out these slides as usual after the call, so you will have her email address there, and it's, I believe, also in the newsletter that you all should have gotten on Monday. Okay, and so I realize this is small, but this is what the knowledge confirmation survey looks like. It's these 10 questions. You need to have the parent go through this at the end after you have consented them, and answer these questions and then upload it with your consent into the consent management system. And we've had just some trouble with that as well. So we wanted to remind everyone that this should be done. I know some of you are randomized to the group that has a poster that you present, and some of you do not do that. And so you do that as part of your process too, but everyone should be filling out the knowledge confirmation survey at the end. Okay, so we wanted to talk a little bit about reports as well and how you can use those to help throughout the study. So there is an adverse events report, and if what we would like you to do is make sure you're reviewing your adverse events listings so that end dates have been entered for your adverse events and serious adverse events. So that's, you know, after they've been dealt with or whatever the outcome is, we need an end date put in there so that we know that you are actively working on those or have actively worked on those. Okay, the next report is the pharmacy shipment report, and this can be used as a trigger for when to place your study phone calls. You can set a recurrent reminder to review this report and place your phone calls and confirm that your study phone calls have been entered and correspond with the shipments. So you can use that report for that. Also know that you should be getting an email trigger now when the pharmacy shipments go out. But the pharmacy shipment report is a good tool for helping you know if something's going on and it's taking a while to get the medication shipped out. It might be good to reach out to the pharmacy to find out what's going on. That's a good tool for you there. We also have a PRO summary, and this is to review and confirm all your PRO surveys were scanned and received at CHOP, and so you should be sending those along to them. If you all have any questions about PROs, again, please reach out to me. I know throughout the study we've had different questions about where to send them or where to find them. The PRO survey is on SharePoint, and the instructions are there as well as in the MOP, but I'm also happy to talk with you about that or email with you about that. And then finally, early termination. If you experience an early termination, you can use this form to confirm that your entry was completed within the system. Okay, we also have a hospitalization report, and we need to ask ourselves, is it IBD related? If not, does it have a corresponding SAE entered into the system and completed? And if it is IBD related, is it after week 25, and is this a study endpoint? So all of those are important when we're looking at that hospitalization report and filling that out. We have a patient schedule report, and so you can use this to help determine your windows for scheduling study visits. Week 0 is always the week of randomization, and so please keep that in mind, that week 0 is always the week of randomization. And then the provider review needed, since this is how the pharmacy is notified to reveal your study drug, review this report to confirm your provider's review has been completed. And then you can also share that report with providers as a guide to help them complete their reviews. Dan, I think you're on the call. Do you have anything else you want to jump in and say before I keep moving on with exceptions?
I don't think so. I think you'll come back to anything else I would have later.
Okay, great. Okay, so we also have an exception aging report, and this the status is a quick way to verify exceptions have been resolved. And to get to the most current exceptions, you go into the combined trial section of the ICN-2 registry and click View Exceptions. We would love to hear from you on how you're using the reports. If you want to send us an email, let us know maybe any other tricks that are helpful as you go through your reports that you think could help other coordinators as well. We would love to hear that. Okay, so a little bit more about exceptions and entering the matching ICN visit. So each and every post-screening combined visit should have a matching ICN-2 registry visit. That is something we need to make sure is happening because I know the data there has not been as good as we liked. And why is this important? Many data fields such as labs and the SPC DAI are taken from the ICN visits. Exceptions are in place to check for missing data points in both visits. For example, if you enter a combined visit but do not enter a matching ICN2 registry visit, then you will receive an exception tracking for the missing ICN2 registry visit. So some of you may have seen that before. That is what's going on there. And if you enter a partially completed matching ICN2 visit, then you may receive a lot of data element is missing exceptions, checking for missing ICN2 registry data, such as growth status, current height, and current weight. So again, just as a reminder, that is why you're getting those, and you can go in and fix them by entering that data. And then if you get, Kelly Alano put these slides together, and unfortunately she couldn't be on the call today, but she said, if you get the paused for investigation message, she said that should not happen very often at all. But if you get it, if it appears in the exceptions column for a patient, there's a temporary problem with the exceptions processing, and this issue is expected to be resolved within 1 to 2 days, and you may be contacted if we have any questions related to this patient. If this message persists for more than 3 days, please reach out to the help desk. Something's going on and we will have to get in there and figure that out. So please know that that does happen sometimes. It shouldn't happen often. And if it goes on for more than 2 days, to go ahead and let us know. And then some frequently asked questions we get about the reports. What is the date on the patient schedule report? So this date represents the middle of the visit window. And for all visit windows, there's a timeline, for example, 2 weeks before or 2 weeks after. Some are different than others, and those are in the protocol. So please look in there to make sure you're familiar with that. And this report will be updated in the future to include the entire window. So the patient schedule report shows a pink box even though I've entered the visit. Why? This is based on the middle of the window and will be corrected. So for example, if you've entered a visit and it happened after the midpoint of the window that's on the patient schedule report, just know, if it's within the bigger window, you're fine, but on the report, it's still showing as pink. So we will be correcting that in the future to make sure it doesn't show as pink. And then why are there entries on the provider review needed report when the review is not applicable? And this is a bug, and so this will be corrected in an upcoming release later this month. And I know Dan and his team have been working hard on that and plan to get that out later this month. Dan, do you have anything else you want to add there?
No, on this one, I would just say thanks to those of you that have been reviewing these reports thoroughly and have brought these issues to our attention. Really appreciate the real road on the ground experience, and it's not something that we can necessarily always replicate in a test environment. So just thank you is all I would add.
Thanks, Dan. And Kim, anything you would like to add either? Kim Shelley.
No, as always, you've done great. No, as always, you've done great. Thanks.
Okay, thank you very much. All right, just a couple more slides, and then if we have time, we can have some questions at the end. So combined reports, upcoming changes and additions. So these are what's noted is coming up. The concomitant medications report, the out-of-range lab value report, the research labs and biobank sample report, and a dosing report to show all doses, including changes. I know we showed this slide previously, but just so you know, the data soft lock did happen last week, and that I know many of you were working very hard to get all your exceptions taken care of and go through your data and make sure everything was ready for that data soft lock. So thank you very much for all the hard work you did to prepare for that. And so just as a reminder, that's for all sites that had at least one participant on or before December 31st of last year. And so Janine is going to start going through those now, and she will be reaching out to you all if she has any questions or problems. And hopefully, if she reaches out to you, you could respond to her within 2 weeks of notification. And then this is our last slide, as always, who's who with Combine. And I will send these out to you all, and I will also post the recording. I do not have anything else. Mike or Darlene, do you have anything you would like to add?
I have just a few things. And, in terms of the database and reports and exceptions and all of that. You all know that for the combined study, we've expanded on to the Improved Care Now registry database. And all of this is not a off-the-shelf data solution, but a totally homegrown database that Dan and his biomedical informatics team at Cincinnati Children's has developed for ICN and expanded for Combine. We hope that all of these reports are basically ways where we can, show you the data that you've already put in on the data entry forms back to you in a way that helps you follow your patients and follow your workflows, know what's been completed, know what still needs to be done, know what looks like it may be a little bit fishy and firing an exception. So, we hope that you're able to use these regularly, incorporated into your workflows and hopefully prevent us from banging on your door in 6 months or 12 months when we notice problems. So hopefully this will sort of allow you to identify these issues and fix them or prevent them from happening in the future. As we've been building this out for Combine, there have been more than a few bugs and glitches along the way. So thanks to all of you for your patience and for pointing them out to us. And thanks to Dan and his team for being super responsive there. Hopefully the next Improved Care Now study and the one after that and the one after that will build on all of this as well. So the more ideas we have from you, the more we can fix this or improve the system, not only for Combine, but for future Improved Care Now work as well. So, please do try to make the reports work for you and your teams. If you have ideas about other reports that would be helpful for you to manage your workflows better, let us know, and we'll try to build it, or at least take note, so that when we do the next Improved Care Now study, we can bake that in from the beginning.
Okay.
I don't know,
Thanks,
Michelle,
Mike.
if you want to take any other sort of general comments or questions. We have a few minutes left.
Yeah, if anybody has anything they would, any questions or comments, we're happy to hear them. I know we have 3 more minutes, so if anyone has anything, we're happy to talk to you about that.
Can I say one thing?
Please.
I was just thinking of what Mike has said and what the presentation has shared. We also still have some sites that have not randomized even a single patient. So that's about 6 sites out of the 35 active sites. So please go back to your teams and huddle and think about where we can actually change that metric, and just make an effort to identify and approach these patients. I can't believe that no site has had a patient with Crohn's disease not starting anti-TNF in the last few weeks or months. So please think about this.
Thanks, Shazad. Okay, any other comments or questions?
Hey, this is Kim at Nemours, Wilmington. This is I guess, question comment for Dan. The exception report, I'm wondering if it, if this is something easy to do, if there's any way to make it a little more specific, like for when there's a query, like say on the additional lab page or the ConMed page, where you might have like 30, 35 items, and it just brings you straight to that page. It doesn't bring you to necessarily specifically the one that the query is referring to. So you've got to kind of go through all 30, trying to see if you can figure out what's wrong or what's missing in all 30. So I don't know if there's any way on the exceptions report to make it a little bit more specific for some of those pages.
Let me take a look at it, Kim. There could be. Let me take a look at it and see what we can find out.
All right, great. Thank you.
Sure.
Anyone else? It is noon now, so. Okay, well, thank you all for attending today, and we will talk to you later. Have a great day.
Take care. Thanks.
Bye, thanks.
Thanks.